Welcome back, NC State students and families. Um, this is Dr. Maria Mayorga again with you. I am a faculty member in the Industrial and Systems Engineering Department here at NC State. And it is my pleasure today to introduce another colleague and friend of mine, Dr. Julie Swann. So Dr. Julie Swann is the department head and Doug Allison Distinguished Professor in our department, the Fitz Department of Industrial and Systems Engineering. She is also an adjunct professor in the Department of Biomedical Engineering at UNC. We won't hold that against her. And she also co-founded and co-directed the Center for Health and Humanitarian Systems, one of the first interdisciplinary research centers at Georgia Tech when she was there. And one of the things she'll be talking to us about today is that in 2009, she was on loan as a science advisor for the H1N1 pandemic response at the Centers for Disease Control and Prevention, the CDC. So as you know, Dr. Swann's research uses mathematical modeling to enable supply chain systems and healthcare to become more efficient, effective, and equitable. Take it away, Dr. Swann.
Thank you so much, Maria. You know, our audience needs to know we do have men in our department as well. Like most engineering departments, we do probably have more men than women, but we welcome everyone. I'm so happy to be here with you today with our students, our parents, our alumni, and Wolfpack friends. Thank you, Maria, along with the organizers of this class. I think it's a fantastic opportunity.
Thank you.
So,
And as I mentioned, Julie, you were on loan to the CDC for the H1N1 response and vaccine distribution. Can you talk a little bit about your experience there?
absolutely. As many people may know, public health is about keeping people and communities well and healthy. It's actually a pretty complicated system. One very key organization is the Centers for Disease Control and Prevention, who led the pandemic response to the H1N1 virus that came about around 2009 in the spring. Before that, I had been using the skills I had as an industrial and systems engineer to look at research with an impact on society. I had gotten really excited about doing things in healthcare and humanitarian operations like disasters, and I also had experience with supply chains in private industry. 2 years before H1N1 hit, I had been working on computer simulations for pandemics. So then when H1N1, we started getting information about it coming out of Mexico, I really started looking further into it. And when I got the offer to come on loan to the CDC after the first set of cases hit in the spring, I jumped at the chance. So I was working 50% time there in 2009 and 10, where I learned a lot. Now, I'm going to ask Maria to show a picture that shows some components of that public health system. You'll see there are lots of different governmental agencies at the federal level, state, and local. You've got healthcare providers, companies, schools, employers, insurance companies, and more. So the CDC was coordinating a response that included partners across that whole network. And within each state, the state agencies were doing the same. Every day I would attend a briefing that covered the status quo and upcoming changes. The Strategic National Stockpile was distributing personal protective equipment and antivirals. The immunization team was procuring a new vaccine created just for the H1N1 virus. And people were busy laying plans for the second wave that hit in the fall. The CDC did a lot of coordination, but didn't really decide everything because a lot of state and local agencies like to adapt the response to their environment. But every day we were looking at surveillance reports on new cases, hospitalizations, and deaths in the very rooms that were filmed in the movie Contagion, which I know that one of the other participants in the course has talked about. While I'm talking, I invite the students to and other watchers to comment with any questions that they have or with areas where they thought that they saw opportunities for improvement.
Great. And also, we should mention that we have created a short survey that we can also talk about those results later. And it is in your Google chat, YouTube channel, I believe, in the chat. And you'll be able to go in and fill out those questions. There's no right or wrong answer. We're interested to see what you all think. So while the students fill out that survey, Julie, We did have a vaccine for H1N1. So can you talk more about that, the distribution of that vaccine?
Sure. And in addition to students filling out that survey, parents and other audience members, you do it too. For this discussion about the vaccine, it might be helpful to look at the graph that was related to the timeline of what happened in H1N1. So first it came out in the spring and really hit its peak in May. And then it slowed down in the summer because of the way that environmental factors affect that particular kind of virus. That's generally true for influenza viruses in the northern part of the world. The second wave began hitting in August, and it really peaked in October. Unfortunately, the vaccine was not ready at that time. While we do know how to make vaccines for influenza viruses, once we identify a strain, it can be a slow process. And it just turned out that the strain was a slow growing one. So if you look at the graph showing the cases and the doses, you'll see that the vaccine started being distributed around October, and the vaccine distribution hit its peak in December. So that was a big gap that was really important, because back in September and October, there were people clamoring for the vaccine, looking on Google to see if they could figure out where to go to get it, and they couldn't get it because it was in such short supply. But by the time it was December, the demand had declined a lot.
Do you think that we had enough vaccine? What happens if we
So
don't have enough vaccine?
Well, it's a great question. And I would say that as I'm thinking about what's going on with COVID-19, I certainly do have concerns that when the vaccine first comes out, there will be shortages and we won't have enough to vaccinate everyone immediately. So one of the things that agencies sometimes do is to prioritize the vaccine. The CDC did that along with the World Health Organization. And so there's a committee of people that get together. They identify specific groups as a target for as a higher priority based on risk factors and need. So for H1N1, that list included pregnant women, people who were caring for infants, people who were healthcare and emergency services, medical personnel, and interestingly, people who were anywhere in the age from 6 months up to 24 years. And then above that age, people who have medical conditions that put them at higher risk. So diabetes, cardiovascular, those kinds of things. So one of the reasons that is interesting is because college age adults were among the groups of people who were prioritized for the H1N1 vaccine. And that's because the data analysis showed that they were at greater risk for outcomes, for severe outcomes, because it seemed that people who were older had a little bit of immunity to the virus that they had acquired when it had come around previously in previous decades. Now, things are different for COVID. I'm sure we would see something different. But even if you totaled up all of those different people, it was still about half of the population in the US. So there's still not enough vaccine to go around. So the second thing that the CDC did was they distributed vaccine pro rata to the states. So what does that mean? That's a Latin term that they use a lot, but it means by the population. That is, as vaccine was coming in from the manufacturers, they were allocating it out to states proportionally according to the population. And that's, as an engineer, that was a little bit funny for me at first, because I could do the math on the population, and I knew that the target populations were not distributed proportionally across the states. However, as the pandemic response went on, I really began to see more of the wisdom behind that. See, the CDC has a mission to improve the health of the population. And as a federal agency, they have to be really careful that they are fair and that they are transparent about what they are doing. They also needed policies that were defensible when they were called by senators or other stakeholders. So there can be a little bit of a loss in terms of the efficiency, the speed, or the effectiveness, how many people are covered. But equity and fairness are pretty important objectives in public health situations.
Last few weeks ago, Dr. Julie Ivy also talked about equity and fairness when we were talking about the food distribution of the food bank. So similar theme here. I want to remind everybody that the survey is still live. If you want to put in your responses for our questions about vaccines. Also, we have some questions from the audience that I think we can answer now, Julie. They are very relevant. So someone has a question about testing. We're talking about vaccines, but right now we don't have seem to have enough tests, and they're wondering if testing was an issue during H1N1.
It was during the H1N1 pandemic, it was not really as much of an issue. One thing is that influenza tests have been around. The supplies for those are around, and we didn't have to develop a new test. The individual components of that test were also available. So the testing was not as much of an issue at that point. But the masks were an issue. We actually, when it hit in the spring, I remember I went online to go order some masks for my household. I should have been prepared already, but I wasn't. And masks were sold out all over the country for weeks and weeks and weeks. And that's in addition to any potential shortages, by the states and hospitals and other organizations. So there definitely were some shortages, but just not as much on the testing side.
And that question came from Nathan. We have another question from Thusna. She's wondering, she or he is wondering how long the process was to create the H1N1 vaccine, and would we expect the same amount of time to create a vaccine for the coronavirus?
That is a great question. So H1N1 was an influenza virus. And for influenza, we make vaccine every year. Usually back in February, the World Health Organization pulls together a committee and determines what strains they're going to put in the virus for that year. And then it's grown by manufacturers. A lot of it is grown in chicken eggs, actually, and it takes about 6 months for that vaccine, for enough of it to grow to serve the demand in the population. But once we identify a strain and have an example of that strain, we just do the process like we do every year for seasonal flu vaccine. The situation for COVID is different than that. We've never had a vaccine for a virus in the category of coronaviruses. So fortunately, there are lots of different companies and scientists who are working really hard on developing a vaccine. There are some early indications that some of them seem to be getting some success, but it is a much harder problem. And so I do expect in general that a vaccine for COVID-19 could take longer than a vaccine for an influenza virus. And when we talk about a vaccine, I don't think that we'll have just one. I do expect, like we had for H1N1, we may have multiple vaccines from different companies with different characteristics, perhaps for different populations. So you might have a different vaccine for children than you do for others, for example.
So the audience is already thinking like systems engineers. I love it. Jared wants to know, what are the factors that affect the amount of vaccine available once we're able to fabricate a vaccine?
Well, I don't know as much about the production process for a COVID-19 vaccine. It will depend on which of the companies is successful in that. I do know that both the companies and the federal government is investing now to be able to ramp up those production systems, because if we are successful at getting a vaccine, you could imagine that we would want enough doses to cover everyone in the United States almost immediately. And to cover really the whole world. So 7 billion doses. We have never manufactured any kind of medical product at that scale, especially one of this complexity. So they are working now in investing in that manufacturing system and supply chain system so that we will be able to ramp up very quickly, no matter which one of these vaccines is available. But I personally think that there are going to be two kinds of challenges that we'll face at that time when a vaccine is available. I do think that there will be a time period when it will be more limited, and there will, we'll have to really understand what those priorities are that have been decided by medical experts. But then I think there will also come a time period when the challenges are really about scaling up very quickly and distributing very quickly and trying to get it into the arms of people as fast as possible.
Would you like to see the results of the survey at this point?
Sure.
All right, let us show that. So the first question was talking about who should make decisions about the COVID-19 vaccine. Most of the responders, 77% believe the federal government should, and 27% believe state government. And then there was a question about if the vaccine is limited, should it be assigned randomly as a lottery or prioritized by risk level? I think the audience has been listening to you, and they have overwhelmingly said that we should prioritize by risk level, and 95% said that. Now, as far as if we prioritize who should be given first priority, those responses are more varied. 47% believe frontline workers and medical personnel should be. 36% thought people with high risk conditions. And the next, it looks pretty close to tied between children, 7%, and pregnant women, also 7%. And only 2% said people caring for young children, and no one said college age adults. So they seem to understand this, how COVID-19 evolves. So why should we not prioritize college age adults, Julie?
That is a great question. And that survey result there is fascinating, Maria, because, as humans often think of themselves first. But what it tells me in those responses is that people are aware that most college age adults are not at highest risk, that other populations are at higher risk. So people are really thinking about that societal good when they answer it. Now, college age adults do have a very important role that they've been playing in COVID, both now and in the future. And, what a lot of scientists are worried about, we have seen lately that the data is showing that more younger people, young adults are getting the disease. The median age in Florida dropped from something like the 50s and 60s to something like the 20s or 30s in just a few weeks, a small number of weeks. And so what that means is that young people are getting the disease. We do see them in the hospitals, but what we also know is that they can transmit the disease to other people around them, even during the phase when they don't have any symptoms or when they have very mild symptoms. So, we worry about college age adults transmitting it to their parents, their grandparents, their neighbors, their teachers and faculty and staff. So that's something that we really need to be careful about.
So could you tell us more about the logistics and distribution of the H1N1 vaccine? And I think you've touched upon some of that already, and we have some related questions if you happen to be able to answer them. One is about the coordination between the US medical experts and international medical experts related to H1N1. How coordinated were these efforts? And there are questions related to more the manufacturing and R&D process. I'm not sure if you'll be able to touch upon this. And then as you wrap up here, Declan would like to know what are some of the lessons that we could learn from H1N1 vaccine and apply it to the current situation.
Now that sounds like an engineer. Let's fix that system, right? Let's understand it, and then let's fix it. So these are all great questions. The logistics and distribution, and I will say that I work in supply chain, so I look at supply chain. I wasn't always interested in supply chain things, but it was something that I became interested in, and I discovered that it's really important, as we've seen this year, in the challenges with masks and tests and other kinds of things, even toilet paper at the grocery store, that supply chain is really important. So the CDC has a lot of people with backgrounds in public health and medicine and epidemiology, but they don't have as many engineers, and they don't have as many people who have looked deeply into supply chain. They have some, but not a lot. And this is another area where I do think that there are some opportunities for improvement, where there are some lessons, as one of the students pointed out. So the CDC let each state design their own process to adapt it to their system. Generally, that is a good thing. There are some states that really have that control centered in the counties and the cities, and some states have it centered at the state level. Some states might have Native Americans who may be living on reservations, and some states don't. And the states all did it different ways. And then people weren't really anticipating that there were going to be shortages. They thought the vaccine would be ready in time to distribute it widely before that next round of cases happened in the fall. But then there were shortages. And when that limited vaccine, it was allocated to a state proportional to the population, then the state was asked to have doctors and other providers place their orders. Now, here's the key, that took time. And then those orders were passed back to the CDC and the vaccine was shipped out to those locations. So one implication of this particular part of this system was that it was sometimes slow. So this was the time period when vaccine was short and we knew that everybody wanted to be vaccinated, but it was taking 2-3 weeks to get vaccine from when it was sitting in a warehouse to when it was being shipped out the door. And that was really crucial during that time period. And so that's something that we looked at, we studied based on the data that we had available to us. And we did find that states that were faster had better usage of vaccination. And so that's one thing that we need to take as a lesson for designing our systems for COVID vaccine, is that both states and federal agencies should really be thinking about that distribution and thinking about making it as fast as possible. And we need it to have pretty broad access to whatever the target populations are. So it may need to go out to different places. One of our other findings in that study was that if states sent it to specialized doctors, then it might be a little bit less likely to get out to others than if they had sent it to healthcare clinics that might have a broader base of people. And then the third thing that we saw in our analysis and our modeling and computer simulations is that if you have good data on where that vaccine has been sent, that you can improve your decisions. So it's kind of odd to think about this public health system is very decentralized. It's a bit like the supply chain for Coca-Cola. So Coca-Cola doesn't necessarily know when you buy a Coca-Cola and you take it into your house, because Coca-Cola doesn't own that whole supply chain. The only way they know that is if Walmart or Publix or others share that information back with the system. And so if you're able to track where vaccine has gone all the way to that final last mile distribution point, then you know what places have used up their vaccine and need more, and what places still have vaccines sitting on the shelves and they don't need more right now. So that's another way that you can still continue being fair and transparent, but you can improve that system a little bit. But you have to invest in it in advance. You have to make sure that your computer systems are ready for that, that you plan for it. And I certainly hope that that's one of the things that we learned from H1N1 that can help with COVID-19 when the vaccine is ready for distribution. One other point about it, and I saw someone asked about materials. Vaccines sometimes have materials that are preservatives, so they last for a while. And in some states, that preservative then makes that material classified as hazardous waste, which is unusual for us to think about. But California has some rules on the vaccine that they use in that state. And what it meant for H1N1 is that if vaccine was sent out to these providers all over the place and it wasn't used, they had to collect that vaccine with a reverse logistics process, but it had to be treated like it was hazardous waste. So it was an unintended consequence that happened for some of the states that hopefully we can think about ahead of time now.
Great.
Oh, and one other thing that I remember that we learned from H1N1, sorry, is that we also should try to use private industry as well as in partnership with public. So there was an initiative where pharmacies were used to distribute vaccine. In some cases, that required the changing of regulations in a state. Some states allow pharmacists to give vaccine, some states don't. Some states allow it for children, some states don't. But that's another avenue or channel for distribution that could be thought about in advance.
Right. Like for the annual vaccine now, you could get it at your local pharmacy or even at Target, which is
That's right.
where we go.
Here in North Carolina, you can, but not everywhere.
Ah, okay. So we don't have a lot of time, but I do want to ask you this question about behavior and how that has impacted the system, because a couple of weeks ago, we talked a lot about behavior and how sometimes the panic behavior exacerbated these supply chain issues. So if you could talk about that a little bit, that would be great.
Yeah, I'd be happy to. One of the behavioral things was what the doctors and providers did when they placed their orders. So, they thought that they'd be serving all of their population, so they would place these really large orders. And in that time period when the vaccine was short, depending on how that state treated that order, it could be that a doctor was getting more than they could really give out in that time period. The other way that behaviors came in is on individuals in the population. In August and September, there was really high demand for vaccine. But then when it came to November, December, that demand had really gone down a lot. Now, why did it go down? One is because maybe people were frustrated at not having gotten it. But I think a second thing is by the time November and December rolled around, some people had actually gotten the disease already. And so they knew that they didn't need the vaccine anymore. Maybe a third reason is that the seasonal flu vaccine was given out at the same time. And so some people may have thought that they had gotten the H1N1 vaccine when they really got a different vaccine. So there are definitely behaviors for COVID. We know that behaviors matter, whether you're wearing face coverings, whether you're distancing, or whether you're gathering in small groups. Gathering in groups inside. That makes a big difference. And that's one of the things that we're seeing in Florida right now.
So most of the audience are future engineers. So as future engineers and particularly industrial engineers, because that's what all of you should choose, of course,
Absolutely.
how can we impact what is happening in our world? How could we improve the situation for COVID?
That's a great question, Maria. And we do have engineers in our department who are using advanced manufacturing, who built personal protection equipment using 3D printing, and we have others who are looking at growing cells and organs and things like that. My area is more related to computer simulation. So if you'll show a picture, this will help. And the class will be learning about this, I think, next week. But we have a way of representing a disease in an individual. And so here on the left-hand side of the picture, someone starts out as being healthy, susceptible to the disease, and then it's possible that they get exposed to it. And then if they've actually acquired that disease, then they become pre-symptomatic. And from there, if you'll click forward, you'll see that they could move into different kinds of categories where some people remain asymptomatic the whole time period. This could be as much as 45% or even higher among college-age adults, while some people are symptomatic or go to the hospital, and eventually people either recover or they may pass away, if you'll see when you click. And in this red circle here, people are infectious during all that time period. And we can take what we know from the literature, especially from places that did a lot of testing, and we can put numbers on all of that. And then we put it into a simulation. Now, some simulations are aggregate, maybe at the national level, but if you'll see on the next page, the kind of simulations that I've been working with, and Maria, just click through those a little bit. We're looking at agent-based simulations across a network where we have people in households. They're also grouped into schools and workplaces and communities. And so someone's infected, like the little red person there, and then they can infect others who are in their network. And we use that to study both the projection and what might happen with the disease, as well as potential interventions, especially when it links with these kinds of resource issues that we see in industrial engineering. And Marie, if you'll click on the next picture, just to show an example of one of the simulations. This is from a few weeks ago, and this is looking at different behavioral scenarios where people, if there's someone sick in their household, where the entire household stays home during that infectious time period to make sure that they're not infecting others. You can see the actual cases are on the far left of that graph, that little squiggly line that's black, and you can see that we still have a long way to go with COVID. We're a little bit further along, but we do know that because of the infectivity of this disease, the fact that no one had any immunity coming into it, and all of the other parameters, that we're really on a path where we have to do everything we can to try to slow it down so that we give time for the vaccine researchers to come up with that vaccine in time.
All right. Well, sadly, we are out of time because we could talk about this all day. But I am very happy to have been able to join you, incoming students and families. And thank you, Julie, for joining us today. Any
Thank you so
parting
much,
words?
Maria. Well, just, remember that you're protecting not just yourself, but the others. And then I would say, look for ways where you can use your skill set and interests to contribute to one of these wicked problems, whether it's COVID-19 or whether it's some other kind of wicked problem that you discover.